So today we will remember sleep and its associated disorders by a simple table. So first of all, we have neurotransmitters and we say C and G for the Z's. That is, cholinergic neurons and GABAergic neurons will cause the person to go into sleep. Similarly, understand 5-HT, NE and histamine. Serotonin, norepinephrine and histamine are required for arousal. So increase in their level will cause arousal. Now understand these two, serotonin and histamine, are for inflammation and norepinephrine is for stress response. So very crude way to remember is that these two things are things which should awake a person from sleep. So these are the neurotransmitters for arousal and C and G are the neurotransmitters for sleep. Now we have this table. Understand that the waves of the sleep starts from the beta. So we have beta and then alpha, then theta and then sleep spindles and K complex and then delta. Beta, alpha, theta, SSK and delta. We have to remember their frequencies and you will see that from beta to delta we have less and less frequency. So beta B, look at this B. This B, if you can see, has this 13. So if I write this 13 over here and then I write 30, so we have 13 to 30 Hertz beta wave. Let's leave alpha from now and let us see theta. Look at this theta, and here it's bar. Draw this bar twice, 1 and 2. This is 4 and 7. 4 and 7. So theta is 4 to 7 Hertz. 4 to 7 Hertz. Now we have alpha between beta and theta. So it is 8 to 12 Hertz. Alpha is 8 to 12 Hertz. And delta is below theta. So never EG is isoelectric. Frequency will never be 0 Hertz. So 1 to 3 Hertz. 1 to 3 Hertz is delta. Now we have to understand the state and the sleep in which these waves are present. From beta to delta, arousability increases and the sleep deepens. However, there is an exception, and we will see this exception after some time. We have beta, eyes are open and the person is concentrating on task like study. And then the patient gets tired of studying and he closes his eyes and his mind wanders to the time when there was no need to study. After that, he goes to his bed and then from alpha to delta, he goes to NREM 1 sleep. SSK is seen in NREM 2 and NREM 3, in which now the 4 has been combined into, no need to write it now, the delta waves will be present. The exception is REM sleep has beta waves. It should be present when someone is concentrating on a subject. And in this, arousability is very difficult. That is why REM sleep is also called paradoxical sleep, because it does not follow the rule. Understand? NREM and REM, now we are going to talk about only them. So from now onwards in this table, over here to here, we are only going to talk about the sleep. So over here in this beta section, we are going to talk about the REM sleep, and in theta section, we are going to talk about NREM 1, here 2 and here 3. So REM sleep is more towards the end of the sleep and NREM sleeps are more towards the initial part of the sleep. I will take this opportunity to make you understand how the sleep occurs. From beta to alpha, the patient goes to sleep and first comes the REM 1, then comes the NREM 2, then comes the 3, and then person goes to REM. Then the patient will go to 3, then to 2, and then to 1, and then to 2, and then to 3, and then REM, and so on. So as we go into the later part of the sleep, as we go more towards the morning, the REM sleep increases, the duration increases, and NREM decreases. So practically also you will observe the memorable dreams are more towards the end. You will remember the dreams of the morning. And sometimes people say that the dreams of the morning may come true. Maybe. And Harmon understand because awakening is a very stressful thing. Waking up is a stressful thing, so cortisol level is increased in later part of the sleep. So REM sleep increases cortisol, and in an REM sleep the growth hormone is increased. Because waking up is difficult, waking up is a stressful thing, cortisol is increased, the respiratory rate, heart rate and BP is increased, and here all of these are decreased. If you see electroocculogram, REM sleep, the eye movement is here, rapid eye movement, so electroocculogram will show waves, and over here there will be no waves. REM sleep has loss of tone such that the patient is not able to enact his dream. Is present, loss of tone is present, so electromyogram will be negative, and here it will be positive. If the patient does not have this loss of tone, there will be dream enactment disorder, in which the patient will enact his nightmares, how he will violently fling his hands and legs and will vocalize. But there will be no sleepwalking. Sleepwalking will be in NREM 3. Wetting is in NREM 3. So I have taken this mnemonic from first aid, which says flee and pee in NREM 3. And similarly, we have bruxism. Bruxism is tooth grinding. So we have tooth grinding in NREM 2. NREM 2. While sleepwalking and night terror will occur in NREM sleep because they are unrememberable, nightmares which are rememberable are in REM sleep. Final thing which we have to remember in sleep are changes in sleep in depression, narcolepsy, elderly, and benzodiazepine. In depression, the patient will say, I have having vivid dreams and restless sleeps. Why? Because he will be having increased REM duration, decrease REM latency, and decrease NREM 3. He will have terminal insomnia. Why? Because he will use up all of his REM and there will be no REM for the later part of the sleep. So he will wake up 2 hours before its usual waking up time. In narcolepsy, life is equal to sleep or dream. So patient is having beta wave, but he goes to sleep. That is, the patient is living in REM sleeps and there is decreased REM latency or REM sleep disorder. In elderly, all deep sleeps are decreased. So decrease REM, decrease NREM 3. Same with benzodiazepine, decrease REM, decrease NREM 3.